Coming to you from the Dietitians and Nutrition Support Dietetic Practice Group, this is the DNS Member Podcast, where we explore topics relevant to our field. From support line content to nutrition celebrity interviews and everything in between, this podcast is where DNS members can go behind the scenes and explore the driving forces behind cutting-edge nutrition support. I'm your host, Christina Rollins. Let's get started. Well, hey everyone, welcome back to the DNS podcast. Today we're diving into a crucial conversation on weight-inclusive patient care with Dr. Michelle May. Dr. May is a former family physician and recovered yo-yo dieter. Like many people in our current food-abundant, diet-obsessed culture, she has struggled with disordered eating and body image. From middle school to medical school, her unhealthy relationship with food was her secret. But in her medical practice, she discovered she was not alone. Many of her patients were trying one diet after another, really not realizing that restriction drives craving and binging. It's a frustrating process that she calls the eat, repent, repeat cycle. So after healing her own relationship with food, Dr. May founded Am I Hungry? Mindful eating programs and training. And to date, over 800 wellness professionals have been trained to offer this methodology to their clients. She's the award-winning author of the Eat What You Love, Love What You Eat book series that teaches mindful eating to help individuals resolve mindless and emotional eating and senseless yo-yo dieting to live a vibrant life they crave. She's also an associate professor at Arizona State University and has taught a master class for the Calm app. She also recently co-authored a paper on weight-inclusive care published in the Nutrition in Clinical Practice, July of 2022. Dr. May, welcome to the DNS podcast. We're so happy to have you here today.
Thanks so much, Christina, and feel free to call me Michelle.
So let's start with the basics. Can you define what weight-inclusive patient care means, and how does it differ from traditional weight-centric approaches?
When you're thinking about weight inclusive, what you're really referring to is taking care of people in the same way. So regardless of body size, you consider the same testing, the same therapeutic recommendations, and you don't make it all about the weight, which is what the weight-centric approach is. And this is important because weight is not a behavior, so it is not under behavioral modification. So when we're working with people, even if our goals are similar, we're going to approach it in a way that really addresses the behaviors, not some number on the scale.
So for dietitians and other clinicians working specifically in medical nutrition therapy, how can they integrate weight-inclusive approaches into their practice without compromising evidence-based recommendations?
Well, unfortunately, a lot of evidence-based recommendations are also based on the assumption that weight and health are one and the same. They are certainly correlated with certain conditions, but correlation, as you know, doesn't equal causation. So we have to be a little careful about assuming that what we're seeing is always accurate. This is a paradigm that's been in place for a really long time. And so when you read research papers, they will even state in the opening that we have an obesity epidemic and it is causing all kinds of diseases, but they don't put a reference to that because that is believed to be just a statement in fact. And there really is not a lot of good randomized controlled trials that show that weight causes these problems.
Well, as you know, our audience base and who we're targeting with this podcast are nutrition support clinicians. And we know that in the nutrition support setting, we often use weight-based calculations for prescribing both enteral and parenteral nutrition. So how can we apply weight-inclusive principles while still ensuring that our patients are receiving the appropriate enteral regimen and parenteral regimen?
Actually, this may be one of the few places where weight really can be used. So, medication dosages, nutrition dosages, that may actually be one relevant place where body weight can be helpful. Now, of course, as dietitians, you know that it is also going to depend on muscle mass and other factors that may be part of the weight, but affect the drug, for example, drug metabolism differently. So we have to still use our brains, but there's a lot of practices and a lot of research behind how drugs are dosed. So it is a good reason to get a weight and use it when making your calculations.
Well, I want to take advantage of this opportunity and ask you what I think a lot of times is sort of the elephant in the room with clinical care, and that's body mass index or BMI. So we
Mm.
frequently see this being used as a nutrition screening tool. So in your experience, what are some of the limitations of the BMI scale, and what alternatives do we have available that you would recommend for our patients?
Yeah, the BMI is really problematic. It was originally developed way back in the 1800s as a way of measuring the body mass and estimating the body fat percentage of populations. The original studies were done on men in other countries, and ultimately that uh, calculation was picked up by Keyes, and he tried to use it as just an estimation of body fat percentage, but even he did not recommend using it to predict somebody's health. So somehow it got picked up along the way, and clinicians began to use it, and it started being used in papers and studies and insurance and other kinds of places without really good evidence that it helps us predict somebody's health
Mhm.
or risk factors, although that's how it's promoted. We've all seen the green, red, yellow charts where
Mhm.
supposedly you're in, low risk in these different categories. But that's not actually how it looks when you start to look at the data. For example, Tomiyama and their group did a study based on the NHANES data. And actually, when they compared cardiometabolic numbers, like blood pressure, cholesterol panels, other things, to BMI, they ultimately determined that about 75 million adults are being misclassified if you use only their BMI rather than
Mhm.
looking at other numbers to predict their risk factors.
Well, we also know that weight stigma is very prevalent in healthcare settings. So, in your opinion, what are some tangible ways that clinicians can create a more inclusive and supportive environment for their patients of all body sizes?
Such an important question because weight stigma is so prevalent in our culture, we often can't see it. So, one really good place to start is by increasing your own awareness of your implicit bias. Implicit bias is the bias that we have that we're just not even aware exists, but it absolutely can affect the way that we practice. So, a really good way to assess this is to do the Harvard EDU implicit bias testing. They measure implicit bias for all kinds of different factors, but weight is one of them. And maybe we could include a link in the show notes that people could actually take that for themselves. It's highly eye-opening. On a practical standpoint, one of the things we can do is make sure that our waiting rooms, our medical equipment, our practices are inclusive of body sizes so that we're not in a situation where we're trying to assess somebody's blood pressure with a cuff that is inappropriately sized and therefore either determining that they have high blood pressure because the cuff is the wrong size or causing a microaggression by having to say, "Oh, get up! Hang on, I'll get up and get a cuff that's larger for you," and then increasing their blood pressure because they're embarrassed and feel self-conscious because you didn't have the right size equipment for them. So it's things like that that we can really begin to tweak in our medical care that help a lot. The other thing I would suggest is that when you're thinking about tests that you want to order or what your advice will be, ask yourself, what would I tell a person in a smaller body with these exact symptoms or conditions? Think about that, because if your advice begins with lose weight, you may be missing an opportunity to really address behavior change that could be very helpful long term.
Mhm. Well, many patients have experienced harmful diet cycles and restrictive eating patterns throughout their lifetime. So, how can dietitians in particular help move patients toward a more intuitive and mindful eating approach during both periods of acute illness or injury, and then when they're just in general, healthy state?
Yeah, that's such a great question. And it's really how I got so interested in a weight inclusive approach is that my work is primarily around helping people heal their long time weight cycling and yo-yo dieting and other challenges due to the failure of diets to change a person's body weight permanently. In fact, I think most of our patients or clients, they're already aware diets don't work. The
Mhm.
difference is they think that they have failed. They don't recognize initially that diets have a high rate of failure, that relapse is very common, not because they're doing it wrong, but because our bodies are very attuned to protecting us from starvation or from, not getting enough energy in when supplies are low. So when a person tries to change their body size by restricting their eating, our body changes.
Mhm.
We develop a more efficient metabolism to protect us from losing more weight. Food develops increased hedonic properties, so it tastes better, smells better, looks better. And of course, with weight cycling or with yo-yo dieting, we have sort of, I call it the eat, repent, repeat cycle,
Mhm.
where people try as hard as they can to follow the diet rules, and then as soon as they eat something that wasn't allowed, they feel like they've blown it, so they might as well keep eating. When we approach a patient with the perspective that, hey, look, I understand that you've tried a lot of things in the past, and I know that you've been told your primary goal should be to lose weight, but can we focus on understanding a little bit more about the choices that you make and why? And maybe start with one specific or two specific areas that your client is wanting to work on, that they're feeling that they need to or want to address. And a simple example might be their soda intake, for example.
Well, for patients who require long-term nutrition support, again, such as those on tube feeding, how can we approach conversations around body image and nutrition without reinforcing weight-centric ideals? Because the reality is many times we are watching weight very closely, and it is a topic of repeated conversation.
Yeah, that's important again for similar reasons to dosing. And so I would be very explicit with your patient about that and say, I need to get your weight. We do this because we want to make sure
Mhm.
that, and explain what you're doing so that you're not feeding into our cultural messages about body weight and how much it matters in terms of a person's success or beauty
Mhm.
or self-control, but that it's really a medical intervention similar to the way you might take their blood pressure and their pulse.
Well, there's growing research around the health at every size framework. So, how does this framework align with weight inclusive care, and how can we as dietitians incorporate it into our practice?
Yeah, the health at every size is a well-established approach to weight inclusive care. And one of the really beautiful things about it is it looks at these issues through a social justice and lens.
Mhm.
So that makes it really helpful in terms of helping people understand that body weight is not is not an appropriate way to judge another person or to assume you know something about their behaviors or their health or even their health goals. So that can be a really great place to start if you're trying to learn more about how to approach this weight inclusive care for your patients.
Well, Michelle, thank you so much for shedding so much light on this important topic. For our listeners who want to learn more about weight inclusive care in particular, what resources or training opportunities would you recommend?
Well, let's try to include in the show notes some links to some resources like the Health at Every Size references, as well as the review paper that I did with Dr. Malden and Dr. Clifford, who are both dietitians and very interested in this area as well. And it would be great if we could include a link to the weight implicit bias testing that Harvard developed.
Wonderful. Well, we will do that. And again, thank you so much for taking some time out of your schedule. I know you're very busy. You have a lot of great projects in the work. So thank you for taking time out of your schedule to talk with us today.
My pleasure. Thanks for having me.
And listeners, if you'd like to learn more about Michelle's work, be sure to check out Am I Hungry and other mindful eating resources in the show notes. And of course, please visit our website at dnsdpg.org. We've got a library of nutrition support related resources, many of which are available at no cost to our members. Until next time, I'm Christina Rollins. Thanks for listening.